Good afternoon, everyone. My name is Lisa Randall. I am a consultant with NASTAD, and I will be facilitating the webinar this afternoon. So welcome to Advances in HIV and HCV Testing, Opportunities for Prevention and Linkage Programs. I want to do just a little bit of housekeeping before we get started. All of the lines are currently muted. They will remain muted during the presentations. We will take questions at the end of both of the presentations. We'll use a chat function to be able to do that, although we do have an ability to do a question and answer on the phone, and there'll be some instructions at the end of the presentations about how to do that. I think it involves raising your hand on the webinar. We are recording the webinar, and it will be posted online along with the slides shortly after we wrap up, or probably later this week, for you to review and share with others that were not able to join us today. So this webinar is a collaboration between APHL, the Association for Public Health Laboratories, and NASTAD. It's intended to provide you with some information on HIV and HCV testing technologies and strategies, including new and emerging technologies. And we really wanted this to be an opportunity to help inform your thinking about how to make best use of technologies to strengthen and expand HIV and HCV testing programs. And as I mentioned, this is a collaboration between APHL and NASTAD, and so that there are both HIV and HCV programs represented from health departments on this webinar, but there are also public health laboratories participating in this call. And so we wanted to use this as an opportunity to inform and strengthen collaborations within the health department. Alyssa, I think we have a poll that we want to run just to see who is on the call. Is that correct? Ah, there's the poll. Yep. So if you can all take just a couple of seconds to indicate where you are affiliated, that'll help us understand who's participating in the call and maybe tailor some of our remarks. And Alyssa, can you tell me, can we continue speaking while people are doing this? I want to be thoughtful about the technology that I don't fully understand.
Yeah, no, you can definitely keep speaking, and I'm going to share the results once a few more votes come in, but it's looking like we have 65% state health department, 20% state lab, and 20% other, so partners in community-based organizations and other types of outside partners. So I will share.
Fantastic.
Yeah, I will share the results with everyone so you can kind of get that visualization. And then you're
great. Thanks so much. So we're really pleased today to have two experts leading us in the presentation and discussion. We have Dr. Mark Pandori and Dr. Carolyn Wester. Dr. Pandori received his PhD in biomedical sciences from the University of California at San Diego, where he specialized in the biology of HIV infection. He conducted his postdoc research and was an instructor of medicine at Harvard Medical School and the Beth Israel Deaconess Medical Center in Boston. And that specialization was in the fields of gene therapy and viral vector engineering. He joined the San Francisco Health Department Public Health Laboratory in 2005, eventually becoming director of the San Francisco Department of Health. He is certified by the American Board of Bioanalysis as a high complexity laboratory director with a specialty in molecular diagnostics. And since 2014, Dr. Pandori has been director of laboratory services for the Public Health Department in Alameda County. He's also authored more than 50 papers in the fields of virology, biotechnology, public health microbiology, HIV diagnostics, and molecular epidemiology. Dr. Carolyn Wester is a public health specialist, obstetrician, gynecologist, HIV clinician, and clinical researcher. She attended Dartmouth Medical School, completed her residency and fellowship at Rush Presbyterian in Chicago, and received her master's in public health from the Harvard School of Public Health. Dr. Wester's work has focused on prevention, care, and treatment of bloodborne and sexually transmitted infections. Her public health experience includes 8 years in an international setting, conducting clinical trials and delivering patient care in Botswana. Her current role is the medical director of HIV, STD, and viral hepatitis for the Tennessee Department of Health. And her work focuses on the prevention, early identification, and treatment of HIVs, STD, viral hepatitis in Tennessee. So I am going to take the facilitator's prerogative before I turn it over to Dr. Pandori and Dr. Wester to just go over a few brief bits of context to help frame our remarks today. NASTAD periodically surveys our members, as you I'm sure are familiar. And our most recent survey in HIV testing and billing was completed in 2015. And this slide that I have presented right here represents 34 health departments who have completed all of the surveys that we've completed since 2006. And what this represents is that health department programs are conducting or supporting just a little over 2 million tests annually. About half of these tests are laboratory tests. Oops, sorry, I'm trying to get a hold of the technology here. The Association of Public Health Laboratories similarly surveys their members regularly. This is a snapshot from their most recent survey of laboratories related to HIV testing. And you can see here that this shows slightly less than 1 million HIV tests were conducted by public health laboratories in 2014, the most recent year which is available. This is similar to NASTAD's survey, which shows that roughly half of the tests that are done in public health venues are laboratory tests, and there is an overall decline in HIV testing occurring. This slide represents combined survey data from NASTAD and APHL surveys. What this indicates is that almost all state public health laboratories do some form of HIV screening in-house. 32 of them have in-house capacity for the AG assay, or the 4th generation HIV test. And many state public health laboratories also do HCV antibody screening in-house. Relatively few health department programs, however, actually require their contracted providers to use the public health laboratory for either of these tests. Here is one more snapshot of information from the HIV testing survey. We asked a question about how hepatitis C screening is integrated into HIV screening conducted by health departments. And you can see there's a wide variety of settings in which health departments are providing access to HCV screening in the context of HIV testing efforts. But you'll also see that in comparison with the just over 2 million HIV tests, the test volume for hepatitis C is significantly lower at about 147,000 tests. And so this last slide here just represents there are many opportunities for public health that are enabled by the various testing technologies, including those which are emerging. And as I turn this over to Drs. Pandori and Wester, I just want to leave you with some bullets of some of these opportunities that I think will be highlighted in their remarks. So with that, I'm going to turn this over to Dr. Pandori, followed by Dr. Wester, and we're off and running.
Hi, can you hear me? This is Mark Pandori. So I'm very happy to have the opportunity to talk about some of the laboratory aspects of the conversation today. And in particular, what you see here on my goals slide is that I want to talk and give an update on the methods and technologies for screening and for confirmation of HIV testing, and that'll include both lab and point of care. I want to talk just briefly about the diagnosis the importance of the diagnosis of acute HIV, because that plays such a significant role in the choices that we make, or it should perhaps play a significant role in the choices we make when we pick a technology, but it's also played a significant role in the establishment of the most recent algorithm that CDC and APHL have put out that we follow for HIV testing. And then, of course, I want to talk about that algorithm and give a review of that and to point out some of its pros and cons, so to speak, at this point of the game. I'm going to then migrate into HCV testing, talk about what some of the current options are and the current recommended algorithm for testing for HCV. And then I want to talk about how labs can integrate HCV and HIV testing in furtherance of facilitating their programs. I'm trying to find the controls here. Oh, there they are. I'll start with HIV screening tests. So when we talk about HIV screening tests, of course, we're talking about really two branches of screening tests. We're talking about what we call immunoassays, and there's a variety of those. They may be enzyme immunoassays or chemiluminescent, but you'll always see that IA. And that means you're dealing with a laboratory-based screening test. Then there's really what's become the majority of most screening, I think, in a lot of jurisdictions, and that's rapid or point-of-care testing. And examples of that are the, I guess, somewhat famous OraQuick, or maybe some places use StatPack, and then there's the more recently approved Alere Determine as well. So I wanted to start by talking about the lab-based screening tests, and I'm actually going to go all the way back to the late 80s, or actually the early 90s, and talk about first-generation tests. These were the first tests that became available, and you may be wondering why I'm going back into such ancient history, but the reason I'm doing that is because these so-called first-generation HIV tests are actually still on the market, and they have relevance on the market and in some screening programs, because it is a first-generation test, as you've seen at the bottom of the slide, called the Aviok HIV-1, which happens to be the only FDA-approved test right now for lab-based oral fluid testing and also for dried blood spots. These tests detected what we call only IgG. That's the antibody that comes up later in the course of an infection, and I highlight that only because I'm going to be talking about what we call window periods during the course of this, and the consequence of detecting only IgG means that you might have a longer window period, but I'll be more clear about what I mean by that in a few slides. There are third-generation tests. We're going to skip over the second ones because they're not in popular use in the United States, but still in somewhat popular use are what we call third-generation enzyme immunoassays, or immunoassays in general. These are different than first in that they can detect what we call IgM and IgG, and the relevance of that, detecting two different antibody classes, is that IgM is visible earlier in an infection, so that means that third-generation tests have shorter window periods, and that is relevant, again, when it comes to the detection of recent infection, which I'll get to in a bit. There are, and these are probably the most commonly used screening tests in labs now in the United States, or at least it's encouraged that they should be, and those are fourth-generation immunoassays, often sometimes called combo assays because they detect a combination of HIV antigen and HIV antibody. That is to say, they detect the antibodies that the body makes to HIV, but they also detect the HIV particle itself. The significance of that distinction is that by detecting HIV antigen in addition to antibody, we can have even shorter window periods for this test and can detect down into what we call acute or very recent HIV infection. Most fourth-generation tests don't distinguish between the antigen and the antibody when they're positive. I've clicked over to some examples. The Abbott Architect is a popular automated combo test. The Biorad GS HIV is a common combo test that can be run in a manual or an automated platform. There's an Advia Centaur, which is another fully automated combo test. And then there's the Bioplex in the bottom left corner of that slide. The distinction between the Bioplex and the other three is perhaps somewhat significant. This is the most recent laboratory-based test to gain FDA approval. It's run on what's called a Bioplex platform. It's a little, it has all the functionality of a fourth-generation screen, but the distinction is that it tells you why it's positive, so to speak. It'll say whether it's positive for HIV-1 antibody, HIV-2 antibody, or if it's positive for antigen. So instead of just getting a positive result and you're left to wonder why that positive result exists, this one differentiates. We could flirt with the idea of calling it a fifth-generation test. Its sensitivity for antigen is supposedly, at least in the package insert, higher than those of the other fourth-generation tests that I highlighted. If that, what we don't know is whether that increased sensitivity for virus detection translates to a decrease in window period. If it did, maybe the moniker of fifth generation would make sense, but for now, it has the, the functionality of a fourth generation test along with differentiation. I want to move on to what is formally called supplemental testing, also known as confirmation testing, perhaps more colloquially in the field. These are tests, when we refer to confirmation or supplemental tests, we're talking about the tests that confirm a positive screening result. Right now, all confirmatory or supplemental testing is laboratory-based. There are no point-of-care tests that are recommended as a final confirmation test. I put the MultiSpot up as one current option, and it's a bit foolish that I did, because you can see I'm telling you right there on the slide that it came off the market in December of 2016, but I thought it was worth noting because certain very high volume, very large reference laboratories stockpiled a lot of these tests. And in fact, there are still some MultiSpot results dribbling out. The MultiSpot, we called it a differentiation test because not only would it confirm a screening test result, but it would differentiate whether that screening test result that was positive for antibody was positive for an HIV-1 antibody or an HIV-2 antibody. You might still see a few of these dribbling out, but I think we're just about done with these confirmation tests. What is more popular, current, and commercially available and recommended is the Genius HIV-1/2 differentiation test by the same company that puts out the MultiSpot, or did put out the MultiSpot. The Genius is what you might call a rapid Western blot, for those of you that are familiar with the Western blot, which was the previous most common confirmation technique. The Genius this is a relevant thing to point out to call it a rapid Western blot, because unlike the MultiSpot, the Genius actually looks for antibodies to a lot of the components of HIV particles. So in doing so, one might say or accept that there's more specificity to this test than there is to a MultiSpot, because you have to be positive for multiple antibodies to multiple portions of the virus. And you can see on the bottom, it detects antibodies to quite a wide range of portions of the virus, not only HIV-1, but HIV-2. So, of course, it differentiates between antibody to 1 and 2 in a very specific manner. There is an additional FDA-approved option for confirming. It looks like I skipped a slide, jumped there. How do I go back? Oh, there we go. There is an RNA-based confirmation test based on what's called TMA. That's not important. It's just a method. I don't know why the slides keep jumping. There we go. TMA is a method of amplifying RNA. This is a confirmation test that detects RNA qualitatively. And like I said, it's FDA approved as a supplemental test. It's very sensitive. It can detect down to 30 RNA copies per mil. To put that in some perspective, there's generally about 2 RNA copies in a virus particle. So this test is very sensitive in that it detects about 15 virus particles. It's different than the other confirmatory tests because it detects virus and not antibody. Moving on, you might wonder, okay, I've told you now about all these laboratory-based tests, and I keep talking about window periods. If you look at this slide, what you're seeing is that if you had an infection event on day 0, and along a time axis, the arrow axis on the bottom, the number of days, First generation tests have a window period of about 36 days. That is to say, it would take a median of about 36 days for a person after the infection event to become reliably positive on a first generation test. You can see that there's a big jump to third generation tests, the significance there being that you're detecting IgM and IgG, and so your window period drops to almost 3 weeks. You can see that there's a further drop with regard to using a fourth generation immunoassay, and that gets us down somewhere in the neighborhood of 16 or 17 days. And that's in large part because one is able to detect virus and antibody with that test. So I wanted to show you this test, this slide to also point out that there is in fact supplemental testing on this time axis. So supplemental testing, like a Genius, would have a window period down around a first generation based test. So I'm going to move on now and talk not about laboratory tests, but about the screening tests that are available as point of care options, also known as rapid tests. I think the vast majority, if not everyone on the call, is familiar with these. They are, interchangeably called rapid or point of care. From the laboratory perspective, these are what are considered waived in terms of complexity, which is something that CLIA and the FDA apply to tests. There's high, moderate, and waived complexity testing. These tests, the significance of being waived means that unlicensed individuals can run these tests, hence they can be run at point of care. If a positive result is obtained on a point of care test, a specimen must be drawn and it must go to a laboratory for confirmation. Remember, there are no point of care based confirmatory tests. These are some of these tests have gotten pretty sensitive, and so what we're seeing is a lot of labs that are running these as random access screening tests as well. There's several rapid tests available on the market. The most common is the OraQuick rapid test. This is a pad that can swab the gums. It can use either finger stick blood or oral transudate, and in about 20 minutes you get a positive or a negative antibody result. Very similarly, there's the Clearview Stat Pack, which, unlike the OraQuick, is usable only with blood and plasma, but has similar capability in terms of sensitivity to the OraQuick. There's a Unigold rapid test out on the market. The distinction here is it uses a lot more blood and detects IgM. Some reports have indicated it may have shorter window periods, and it's a faster test in that it takes about 10 minutes to do. There is the INSTI Bio Litical test. This is pretty fast. It is distinctive from the other rapid tests in that it takes about 60 seconds from after the specimen is loaded and the chemistry is loaded into the device to get a result. And it's fairly sensitive in terms of being able to detect IgM and IgG. Another significant advance in rapid testing recently has been the Alere Determines FDA approval. This rapid test, as you can see, is a little different. It's an antigen antibody rapid test, and on the far right, you can see that there's therefore two results that come out of a test like this. One result for antibody and one result for virus detection. Various reports indicate that it may have relatively low sensitivity for antigen, maybe in the perhaps around 1 million copies RNA equivalent, but that might still be capable of detecting acute or recent infection. And it has, in some reports, pretty high sensitivity for antibody that rivals, in some cases, third generation lab-based tests. So if we go back to our trusty window period slide, and we're wondering where rapid tests sit on this time axis that I showed you earlier, again, you can see where supplemental and lab-based testing, supplemental and screening lab-based testing sit. Rapid IgG tests, like the OraQuick or the Clearview Stat Pack would be out around a first generation test, but there is some data indicating that when rapids are able to detect IgM, they advance a little bit closer to the sensitivity of lab-based tests, and so have shorter window periods between the infection event and when an infection can reliably be detected. So when you look at that window period slide, we have to really notice that we need to mind that gap very carefully. The gap meaning that window period gap between the screening test window periods and the confirmation test window periods. A long time ago, when screening tests were positive and Western blot results were negative, we might consider that that was a failed confirmation and therefore a specificity issue. But what we are learning is that because of this sensitivity difference between screening tests and confirmation tests, that people that are positive on a screening test and negative on a confirmatory test might very well be recent or acute infections. And our new, or our relatively new algorithm in the lab seeks to be mindful of that. So I want to talk briefly about recent and acute HIV infection, because I've been implying that it's important by continuously talking to you about window periods. And so what we see, what do we mean by an acute infection? Well, I think there's a lot of different definitions, but really what we're talking about is recent HIV infection. We might all agree from a diagnostic perspective that we're talking about, let's say, pre-seroconversion infection timeline. This would be an approximate 3 to 6 week period before a person starts to develop antibody. If you look at it graphically, here's a typical course of HIV infection. And what one sees is that very early in infection, RNA levels skyrocket in the blood. And it isn't until about 3 weeks later that IgM and antibody becomes detectable. So there's that gap where an infection could be detected if a screening test detected virus, but not antibody. And what's really important about that high viral load early time period is that that viral load in the blood correlates with viral load in the semen. And so that means that people are, the research has directed us to the fact that there is in fact a higher probability of transmission during that acute and recent infection time. So the ability to detect infection then when people are most infectious is critical, and so we should be mindful of this when we look into our programs and decide whether to use rapid tests or what lab-based tests we're actually going to utilize. If we go back and we look at our window periods in regards to in regards to acute infection, we're really talking about this time period before antibody-only tests would be reliable, would reliably detect infection. So viral RNA tests would be a way, for example, to detect very recent HIV infection, but also fourth generation tests detect antigen, and as you saw in an earlier slide, can detect HIV infection in that acute and recent phase. Talking about the direct detection of virus, what we're really talking about is RNA detection, and there are a number of commercially available options to detect RNA. They're shown on this slide. The difference between the three with the asterisks that don't have a box around them is that they are not FDA approved for diagnosis. They can be ordered by a physician for any reason that the physician needs in furtherance of the care of their patient, but the Hologic in the box is the only one that has FDA approval for diagnostic means and as a supplemental test. This leads us now to the current recommended laboratory algorithm. As a reminder, the current algorithm says that HIV 1-2 antibody antigen combination immunoassay is run. If it's positive, if it's negative, the screen is over. If it's positive, then an HIV 1-2 differentiation test is utilized. In this case, most commonly, that will be a Genius, and that will include the following considerations, and that is HIV-1 positivity. You might have HIV-2 positivity, or you might detect both antibodies in the differentiation test. If the differentiation test is negative or indeterminate, what we see is that we have to reflex in this algorithm to a nucleic acid test. And then if that nucleic acid test is positive, that indicates recent or acute HIV infection. And if that test is negative, then we declare it as negative for HIV-1 infection. The benefits of this algorithm, as you can see, is it's sensitive for recent HIV detection. It can discriminate between infection with HIV-1 and 2. It can say whether or not somebody is recently infected. Because it uses the Genius, or it used to use the MultiSpot, the turnaround times are a little more rapid than using Western blots. So the work on the supplemental testing end for lab people is just a little bit lower. There's a couple of issues. It relies on singular products, such as the Genius, which is essentially a little bit of a monopoly on confirmation. And in regard to dealing with RNA, there is only one RNA test that's FDA approved on the market right now for supplemental testing, and that's the Hologic test that I showed you on a previous slide. And there is still no HIV-2 RNA test. I'll migrate now to HCV testing, for which there's a little bit less to say. In general, HCV RNA is detectable in about 1 or 2 weeks after infection, and antibodies are detectable about 6 to 8 weeks after infection. It can take several months for antibodies to develop in some cases, but most people should have detectable antibody by 6 months. In some cases, infection resolves on its own, and if that happens, RNA would be undetectable, but there would be a persistence of antibody markers. If infection becomes chronic, RNA would be detectable for greater than 6 months after onset. Graphically, you can see that gradually over several months, antibody levels rise if persons infected with HCV. Very early in infection, as we said, within a couple of weeks, RNA levels get to be very high and stay that way unless the person happens to spontaneously clear it. The recommended testing sequence for HCV begins with an FDA-approved immunoassay, very much like our HIV recommendations, to screen with an antibody. There is a rapid test. Available, the OraSure OraQuick, that's FDA approved for screening for HCV as well. So if either a rapid test or the lab-based antibody test is positive, the testing must reflex to an HCV RNA test, which is a laboratory-based test. Whoops, next slide. Graphically, here's the algorithm. You can see at the top, we test for one test for HCV antibody. If it's non-reactive, the algorithm ends. If it's positive, then we reflex to an RNA test. If the RNA test is positive, that tends to indicate current HCV infection. And if the test is negative, then the reflex to not detected. And that means that there may not be current HCV infection available, and additional testing would perhaps be warranted in that case. There are several FDA-approved HCV antibody tests, both from Abbott and Siemens, and also from Ortho. As you can see on this list, there is a rapid test that is FDA-approved, and it's by OraSure. Similarly to the same company, obviously makes the OraQuick for HIV. In terms of RNA tests, there are several. But we break them down on this slide with regard to what claims they have. There's those that are approved only for quantitative patient management, and that measure quantitative load. Then there's some that have a qualitative claim, which means they can confirm, according to the FDA, they're usable to confirm an antibody test result. And then there's those that have a dual claim and are usable for both. And you can see all of those clearly on this slide. There are some tests coming. There's a protein test, which would be cheaper than an RNA test, which we call HCV Core. There are some more NAT tests coming, and there's Cepheid, which is a rapid RNA testing platform that's somewhat moderately complex, and that is available from Cepheid. From the laboratory perspective, it's really very easy to integrate HIV and HCV testing, and I'll get to that on my next slide. But it's also just want to point out that, in terms of testing integration, there are point-of-care screening tests for both of these, and I think I've made that plain. For HCV, there is the OraQuick, and then there are several choices, obviously, for HIV. So from a point-of-care testing program perspective, there are rapid tests available for both. From the laboratory perspective, the tests on this slide indicate clearly that the tests for which HIV and HCV can both be run on these platforms pretty interchangeably. So if a lab has one of these platforms, it's not at all difficult to perform both HCV and HIV testing. From the nucleic acid amplification perspective, these are platforms that are common in laboratories that would be used for HIV viral load, but can also do RNA testing for HCV. So again, whether you're looking at a point of care option or looking for an antibody screening option or looking for an RNA testing option, labs have choices amongst the equipment that they can get that would integrate both HCV and HIV testing. So I'll end in summary and say that the new, or well, it's relatively new now, the current HIV algorithm allows for programs and labs to play to the strength of new technologies, and that is the shorter window periods and the ability to detect recent infection. And whoops, my slide went, there we go. There are many opportunities for labs to integrate their HIV and HCV testing operationally, as I just pointed out, because there's plenty of technologies out there that allow this integration. And so I wanted to conclude and say thank you for your attention, and I'll look forward to your questions.
Great, thank you so much, Mark. And I will just note that we'll answer questions at the end of Carolyn's presentation. We've received a few questions so far, and we will make sure that they're not forgotten. And I'm going to turn it over to Carolyn now.
Thank you so much. So my name is Carolyn Wester, and I'll be presenting for the next 15 minutes or so about experience as well as challenges and opportunities from the health department perspective, specifically Tennessee Department of Health. And I'm, unfortunately, let me see if I can get the slides to advance. Alyssa, it's not working, I'm sorry.
Do you want to just say next slide and then I can advance them?
Sure, thank you. So next. Great. And next, please. So very briefly, first in the context of HIV testing and then Hep C testing, we'll give brief background of kind of where we've been and where we're going, and then challenges and opportunities as well. Next. To start with HIV testing, this graphic just gives you a little bit of an idea of tests conducted as represented by the bars, and these are tests that have been conducted using state and federal funds. They do not include tests conducted through private providers. But the point being that from 2008 to 2014, we saw approximately 30% increase in the number of tests conducted, and those were primarily among disproportionately affected populations with targeted additional kind of routine opt-out among disproportionately affected populations. At the same time, the number of newly diagnosed HIV infections in our state went down by about 25%, and that trend continued to go down for 2015 and 16, although they're not depicted here. Next slide. And this is just a larger representation. If you follow the black line, those are newly diagnosed cases within Tennessee. We are now at about 700 for 2016. The red line, new AIDS diagnoses. The green line, which has a spurious drop from 14 to 15 because we didn't have death match data available for that. But all of those are good indicators that despite increased testing and vigilance, our numbers are improving. Similarly, with the blue bars, you can see that the reported persons living with HIV is increasing as people are gaining access to care and treatment and living longer. And the gray bar is plateauing, which is the reported persons living with AIDS, representing that hopefully people are gaining access to diagnosis earlier and earlier. Next slide, please. This just demonstrates an exercise that we did in early 2012 when we were building our first continuum of care. The dark red represents what our baseline numbers were for 2010. And of course, that was in the context before at least Tennessee had comprehensive viral load and CD4 reporting, and which was established at the beginning of 2012. But we used the data that we had, and we basically projected for 2015 that we did not want to lose, at least beginning with diagnosed. We don't know what our state-specific undiagnosed fraction is, so we started with diagnosed and didn't want to lose anybody, more than anyone, period, but no more than 20% at each step of the cascade. So the gray superimposed bars represent what our 2015 goals were. Next. In the lines of basically progress, this was a progress report based on our cascade of care data. And the top 3 rows, you can see basically what our progress was in terms of linkage to care, and that was within 3 months because it was based on the first national HIV/AIDS strategy, as well as increase in retention and increase in viral suppression. So we were moving towards those goals in the first 2 rows and have achieved that goal. Obviously, lots more progress that needs to be made, and our 2020 goals have now been established, not only in higher percentages, but of course, more rapid linkage to care as well. And then the bottom half of the table represents that, of course, we want everybody to meet or exceed those goals in the top half, but we want to make sure that no group is left behind, and therefore we picked groups that were disproportionately affected in terms of viral suppression and wanted to make sure that they were achieving at least a 20% increase. And by 2014, all of those groups had. Next. This is just a regression analysis that we conducted with our partners at Vanderbilt through our CFAR, and it also just represents basically, we conducted this type of analysis at each step of the cascade for linkage, as well as engagement in care, as well as viral suppression, but they all look similar. And the groups that were more likely to have a less favorable outcome were those who are younger, racial ethnic minorities, and people with either a past or present history of injection drug use. Next. In terms of our experience with testing specifically, we have a wonderful state lab that's very responsive to our program needs. And you'll see that not only with their implementation of 4th generation testing in 2013, but also, and I get to the HCV slides, but this represents our data from initiation of 4th generation testing. So all of our state lab testing is conducted from an HIV perspective using 4th gen. And from April 2015 through June 2015, nearly 180,000 tests were conducted. Of those, 1.1% were, or 1960, which is in our 3rd row, were positive for step 1 and therefore went on to step 2. In step 2, 90% of those individuals who were positive on step 1 were confirmed using MultiSpot as being positive. And we also picked up 2 HIV-2 tests that would have been otherwise, or 2 HIV-2 positive individuals that we would have otherwise missed. Of those individuals that went on to step 2, 184, or about 10% of the step 1 positives, were actually negative or indeterminate on step 2 on the MultiSpot. So they went on to step 3 for RNA testing, and we use the Aptima and a qualitative RNA for confirmation. Of those 184, 26 or 14% of the samples, 14% of the discordants that went on to step 3, or 0.01% of all samples submitted, were positive for RNA and therefore determined to have acute infection. Next. So in our lessons learned from this, and of course it's still ongoing, of samples that went on to step 2, about 90% were confirmed. 2 cases of HIV-2 were detected. Of the samples going for RNA testing, about 90% of them ended up being negative and about 10% were determined to be acutely infected. Interestingly, of our 26 acute infections, 24 were referred to care, 22 were actually linked to care. 2 were refused, we were unable to follow up. But of the 22 that were linked to care, 19 of them were determined to be indeed infected and get into care for the first time. 3, however, 1 was determined to be chronically infected. We knew that because he had been infected at birth, and we had a number of labs to demonstrate that. And then 2 were determined to be HIV negative, and these were individuals who had undetectable viral loads who were then followed by repeat screening and were turned out to be negative. So I just bring that up because it's important in terms of counseling. And it also made us kind of think about, I know that Mark just kind of mentioned that there's no quantitative test that is FDA approved for diagnosis in the HIV context. However, there may be utility if one is forthcoming because we can see if it's positive on a low level or not. Next. So outside of the state lab, our experience with using HIV testing in community-based organizations, we are partnering AIDS service organizations throughout the state, and they're conducting testing in clinical as well as non-clinical settings. You can see the number of tests conducted, the positivity, and then of those who are positive, how many were actually newly diagnosed in each of the columns. And on the bottom, you can see in 2016, they had nearly 50,000 mostly point-of-care tests conducted by community-based organizations with a 0.7% total positivity rate and 0.4% total positivity of newly diagnosed. And the newly diagnosed is determined not by self-report, by the matching in our HIV surveillance database. Next slide. So just to kind of summarize before I move on to HCV, and this is comparing 2015 to 2010, so a little different than the slide earlier, but basically the implementation of fourth generation testing occurred during this period. Our new diagnoses, new HIV diagnoses decreased by 17%, late stage HIV diagnosis by 9%, and our HIV deaths by 20%. We definitely have made some progress, however, challenges persist, particularly among our younger individuals, racial ethnic minorities, and also individuals with a history of current or past injection drug use. And another challenge is that a lot of our high impact strategies, obviously because of limited resources, we want to focus where the disease burden is. And so we have basically focused efforts on testing, particularly in the community where we're going to have higher percentage rates of affected population. However, in the context of the next bullet, which I'll get to in just a second, we have a lack of testing in low prevalence, high risk settings where we're vulnerable to an outbreak. And that brings us to the quote at the bottom of the page, particularly among persons who inject drugs, who are at increased risk for HIV, Hep C, and Hep B and other negative health outcomes. Basically, we are concerned about an outbreak of HIV superimposed in HCV. Next. In that context, I'm going to switch over to Hep C because obviously they're incredibly linked, particularly among our individuals with a history of injection drug use. Next. This just gives a little bit of snapshot of acute Hep C in Tennessee. If you look at the rank on the bottom row of the table, we've had pretty much been in the top 5 in terms of highest case rates in the country. And this is just a map from 2010 to 14 of a scatter plot of where those acute cases are. And you can see them primarily among our eastern corridor. Now again, this is just the tip of the iceberg. We know that these are reported cases that have been investigated and confirmed. We also know that more than 70% of acute cases are asymptomatic, and so they won't fit the case classification. We also know that different areas are testing at different rates than others. So reported is going to be impacted by testing and vigilance kind of surveillance capacity as well. But this is what we know, and even of what we know, we've got very high case rates. Next. This was in the MMWR in 2015, and Tennessee, along with Kentucky, West Virginia, and Virginia, showed on the left increasing rates of acute Hep C, specifically like a 364% increase. The light bars represent case rates going up in non-urban areas, and the dark bars represent case rates going up in the urban areas. So an increase in both areas, particularly concerning case rates, at least in our rural areas. And on the bottom right, although not meant to be representative causative as here, but certainly related, you can see the percentage of all admissions to substance abuse centers by persons of the same age, which is again less than or equal to 30-year-olds in those 4 jurisdictions. And so you can see the opioid admission rate going up, driven primarily by prescription opioid admissions, but with the advent of controlled substance monitoring databases in our state and other neighboring states in 2012, with the prescription opioids becoming harder to get, you can see the increase in heroin admissions. Next. We clearly in our state, and I know in a number of other states, are on the verge of, well, already have an intersection, but are certainly trying to avoid a further intersection of the intersection of these three epidemics. Next. And courtesy of the CDC's vulnerability assessment, which was published in JADES, this is our Tennessee profile, county level, and of the 225 counties that were identified to be similar, at least demographically, to Scott County, Indiana, where the HIV Hep C outbreak was, our state was home to 41 of the 220 counties. You can see a number of those are along our northern border that we share with with Kentucky, I'm sorry. Next. Our newly diagnosed HIV cases, which are represented on the Coral Plus map on the top, are primarily concentrated in urban areas presently. Shelby County, which is where Memphis is in the bottom left, Davidson County in the center, which is where Nashville is. Those two counties themselves, as metropolitan areas, count for about 2/3 of our newly diagnosed HIV cases as well as prevalent cases. The remaining third is balanced throughout the state with slightly increased concentrations in Knox County, which is Knoxville, and also Hamilton County in the southeast, which is where Chattanooga is. That's a little bit different than where our acute HCV cases are, which you can see in the bottom Coral Plus. And there, it's primarily along the eastern corridor. Just think back to the scatter plot map that we just looked at. Although we definitely have some metropolitan areas where we have some overlap, including Knoxville or Knox County and Davidson, where Nashville is. Okay, next. So as we build, this is Scott Holmberg's continuum of care, continuum of cure for Hep C. And as we start building what is the capacity that we need to kind of stretch from beginning to end for our continuum of care, you can see testing is clearly at the center of it. Next. And this slide just highlights some of the activities that we are trying to address, but you can see highlighted at the bottom our Hep C testing. Our Tennessee Department of Health State Lab has built the capacity for antibody with reflex testing to RNA. And we're in partnership not only with expanding testing in the health departments through state lab, but also through community-based organizations using rapid test kits. Next. So a little bit of experience. I'll start first with the CBOs. We have an HCV testing project. And basically, we provide rapid antibody test kits to the community-based organizations who are serving at-risk populations. And these have so far primarily been the partners that we work with in our HIV prevention program. The reporting requirements are pretty basic. We need a monthly report. We also do site visits just to make sure that their logs and controls and all that are okay. And then we have a line item report that is required for everybody who tests positive on the antibody test. Next. This is just a snapshot of the monthly report. You can see it's very basic. It's just aggregate for months. Next. And then the line item report is for just the positives because Hep C is reportable. And they need to fill this in and send this to us, and we put it in a database here at the central office, but it includes, as you get towards the bottom of the screen, after demographics and setting and all that, the reason for the testing. Next. As a summary of our CBO testing results in 2016, and again, this is, we had 47,000 HIV tests conducted in community-based settings and just 2,000 HCV tests, so we're just at the beginning of this, but with almost 2,200 tests conducted in targeted settings, there was about a 33.5% positivity rate. Next. So as we move towards building the capacity in the health department for HCV testing, we've been working with our state lab, and as I mentioned, they built this capacity. We were able, with some supplemental funding through an EPI-aid, to be able to pilot this from June to October of last year. It was piloted in 3 metropolitan health departments in eastern Tennessee, primarily in STD and family planning clinics. There was a basic risk factor assessment at the time of sample collection. We developed protocols for specimen transport as well as pre and post test messaging, referral information, and there were 2 additional analyses, with neither of which I'm going to mention in this. Next. And you can hit those a couple until it's perfect. So, There were about 4,700 tests conducted in those three areas, Chattanooga, Knoxville, and then the Kingsport area, which is Sullivan County. Next. And across those three sites, you can see that 4,700 tests were conducted. The overall antibody positivity rate was 8.4%. This is a relatively young population. Mean age was 31 or 37.3 among those who were antibody positive. And then of those individuals who were antibody positive, you can see, of men, almost 11% positivity rate, 7% positivity rate among women, 15% positivity rate among white non-Hispanics. The positivity rate was slightly higher in STD, or about threefold higher in STD clinics than family planning clinics. And at the bottom of the slide, in the left column, you can see that of all people coming in for testing, about 55% didn't report any risk factor. But by self-report, among the antibody positives, you can see that there was 70 to 75% report of either history or current or past injection drug use, intranasal drug use, or incarceration. Next. So in summary, we have about 8.4% overall positivity rate. Of those, all had reflex testing to RNA, and almost 75% were RNA positive. Risk factors among the population tested, everybody coming in, about 10% acknowledged IDU, 20% intranasal drug use, and 25% a history of incarceration of at least 24 hours. And again, among the antibody positive populations, those rates were much higher, about 70 to 75%. Also of interest, in the females, we defined reproductive ages 11 to 50. They represented 58% of the person's testing, and there was a 6.3% antibody positive rate in that age range. And of those individuals, 5 were actually pregnant at the time of testing. Next. We are planning a statewide rollout. For the sake of time, I'm not going to spend any more time on that. You'll have those slides at your access. Next. And this just shows basically our indications for testing. We developed this in a nursing protocol and a training manual. The second half you can see for repeat testing. We just basically, for nothing other than resource allocation for people with ongoing risk factors, we're asking that they wait at least 12 months for a repeat test if the first one was negative. Next. These were some risk factor questions that we're routinely embedding into our health department screen. We just put pregnant at the bottom because it's easier to extract off of this screen than it is from the chart. Next. And in terms of opportunities, integration of services within the health department, absolutely critical. We've just shown with some of that data that we show that the positivity rates are very high, even in the STD and family planning clinics. It also has an opportunity to integrate other clinical services within the health department. And it also provides, with this reflex testing, an opportunity for our CBOs to send in their antibody positives for reflex testing to the local health department. Some of the challenges, absolutely funding, not only for the testing, which includes the lab-based and rapid testing, but also the staff to conduct the testing, and then also the clinical personnel. Those are in the field conducting testing, providing basic messaging, and also following up the positives, both with case investigation, as well as prevention services and linkage to care. And ideally, we'd love to have the staff to follow up people who inject drugs regardless of their HCV status so that we can get them referred and linked to other services as well. I have an acknowledgement slide, and that's it. So I'd just like to thank everyone at TDH, as well as the FBA team, our community-based partners, all of our local health departments, our CFAR, which is sensational, and then, of course, NASTAD and APHL for the chance to present today. Thank you.
Thanks so much, Dr. Pandori and Dr. Wester. This was tremendously useful information, I think, and we covered a lot of ground. I want to acknowledge the fact that we have a number of questions that have come in, both on the chat function and on the Q&A, but we are at the top of the hour. So what I'd like to do, Alyssa has informed me that we won't get the hook completely, at this, but I do want to be respectful certainly of our presenters' time, but also of our participants' time. If we can take a couple of these questions and stay on for a few minutes, maybe 5 or 6 minutes, I think that would be really helpful. Mark, you've already answered a couple of questions that came in through the chat. There was a question, I think, for Carolyn regarding your regression analysis. And I think the question was, how are the virally suppressed individuals lower than the number of individuals on ARV?
Great. So, yeah, I'm sorry I didn't make that clear. So that was actually on the slide where we had our 2010 baseline information, and then we superimposed our 2015 goals. And so complete viral load and CD4 reporting wasn't instituted until January 1st, 2012. So that's the baseline slides where it showed a dip in engagement and then a rise in suppression was probably simply because we didn't have complete reporting. And so engagement required at least 2 CD4s or viral loads in the same evaluation year more than 3 months apart, whereas viral suppression required just at least 1 viral load in that evaluation year, with if the last viral load, if there was more than 1, or the only viral load, if there was just 1, being less than 200 copies per mil. So someone could be suppressed if 1 viral load made it in, but not necessarily make the definition for engaged. And again, that was simply because of it predated comprehensive reporting.
Thank you. There's a question that has come in regarding HIV and HCV RNA testing, confirmatory testing. I think this is one for Dr. Pandori. It's in the Q&A, Mark, if you can look at those. The question is, can confirmatory HIV and HCV RNA testing be done on the same serum specimen as the immunoassay, or does another specimen have to be collected?
It can be done on the same specimen as the original specimen. Being mindful of the fact that if serum was collected as the first, that there are certain of those RNA tests that may not be approved for use with serum. For example, if someone's using an Abbott M2000 in a validated context, that might be a plasma-only test. But yeah, the same specimen can be used.
Terrific, thank you. Carolyn, there's a question that's come in about the health department pilot project. Was MSM collected as a risk factor?
So that's a great question. No, it was not as an independent risk factor. We will, in terms of an indication for testing, everybody who came in through the health department, the STD or family planning clinic was offered testing. So, but no, it was not.
Okay, thank you. Are there other questions that our audience has or that the presenters have for each other?
This is Carolyn. I have a quick question for Mark. Will there be a quantitative RNA, or is there a quantitative HIV RNA test in the pipeline for approval as a diagnostic in the 3rd step of the 4th gen algorithm?
It's an excellent question. Yeah. No, not right. If pipeline is that the FDA is reviewing data, no, there's not, to my knowledge, a test of that nature in the pipeline. I do have some knowledge that certain companies are looking into going into that pipeline, though. So we'll see.
Thank you.
Does that answer your question?
Okay. And Alyssa, do you want to, you've made a plug here about the coalition. Do you want to say a little bit more about that?
Sure, thanks. I wanted to not take too much time, but I'll just say it for a second. So NASTAD this week launched the Hepatitis Testing Partnership, which is a national coalition of a number of stakeholders in HCV testing, from public health to labs to community partners, patients, advocates. And we will be convening on a quarterly basis and then also have a Google group. So if you're interested in joining and learning more opportunities of how we can all work together to increase HCV testing, as this webinar highlighted the need for, please email me at akitlas@nastad.org. And thank you. And thank you so much to our presenters. That was really incredible and informative.
Yes, thank you, Dr. Pandori and Dr. Wester. This was, I think, an incredible opportunity for us to learn from you, and I am very appreciative of your time in pulling this together and participating with us today, and very appreciative to Alyssa for herding all of the cats with the technology and getting us all in order.
Thank you, Lisa. And I just put my contact information there, and I think we are all set, and we'll be sending out the slides and a recording to everyone who participated and to those who weren't able to join us today, as well as making them available online.
Thank you.
Thanks so much. Have a wonderful day.
Thanks so much.
Thank you.